welcome to Module 6, Exercise Behavior Change. I'm Dr. Nicole Culos-Reed, professor in the faculties of kinesiology and the Department of Oncology, Cummings School of Medicine at the University of Calgary. Along with Dr. Courtney Lightfoot, we are going to present on the evidence for supporting health behavior change and key considerations that you may want to have as you move forward with implementing or building exercise studies or resources for management of chronic kidney disease. Specifically, we're going to look at some of the key underpinnings of understanding exercise behavior change, including exercise adherence and exercise maintenance. A brief overview of only a few of the theories that have been used in the literature to understand exercise behavior change, and within those theories, really considerations of key elements to identify and target as you move forward towards what you'll see in Module 8, implementation. Finally, behavior change skills and what we need to target. So beyond an exercise prescription, it's really critical to build the skills within our participants so that they enhance their confidence, see themselves as someone who can move more, who can engage in exercise. And can really build the skills outside of learning how to do a squat or learning how to stabilize their core, but really have the additional skills necessary to support that exercise maintenance. Courtney is going to go into those skills as well as key elements of communication, and I'll come back with a bit at the end around building a habit and some of the pieces that we often hear out there within the exercise behavior change world. Finally, there's a case study to consider to really pull together some of the information you learn throughout this module. So really, it's about moving beyond simply the exercise prescription. When we have that qualified exercise person, the kinesiologist or clinical exercise physiologist, we know we can build an exercise prescription based on FIT principles and other principles of exercise. But really we need to move beyond that exercise prescription and consider what are the other elements of supporting exercise behavior change. Because typically we can get a lot of people started with exercise, but most don't sustain that change. And so there's a real issue of lack of exercise adherence and lack of long-term maintenance. So exercise adherence is really defined as that sticking to it, the ability to engage in a level of exercise behavior. And I would argue that in order to get that, we really need to target some of these other behavior change skills that we'll talk about and get people to see themselves as an exerciser. Exercise maintenance moves beyond just that initial sticking to an exercise program, and it's really that continued adherence. And typically we see that 6 months timeline thrown in there, which may be a bit arbitrary because we know for some individuals a habit is formed very early on and they will sustain and move into maintenance, while others may be doing something for longer than 6 months and then all of a sudden drop out. But oftentimes within the exercise adherence literature, we see reported this 50% dropout of individuals who start exercising within the first 6 months. So we know that initial change can be very volatile. It's not stable. And so how do we build additional skills during that early phase of exercise adoption and moving into fostering adherence so that we are more likely to get an individual moving towards exercise maintenance? In order to help us understand behavior change, it's really useful to look at some of the theories or models that are available out there. And many of these may be familiar to you already. For some of you, this may be new. And so we're not going to go into really in depth on these, but really provide an overview of the theories and what we're targeting potentially within these theories as we move to practice, whether that's within a study and targeting some of these theories to inform what you intervene with, or if we move further on into full-on implementation and building sustainable programming. The theories most often used across exercise behavior change fall under the category of social cognitive theories, whereas you can see here determinants of human behavior include cognitive factors, environmental factors, and behavioral factors. And within a successful exercise behavior change program, we really know that we have to target all of these factors in order to enhance our success at supporting change. And so within social cognitive theories, you'll see elements of targeting and assessing, evaluating the outcomes across these different levels. So whether it's assessing people's attitudes towards exercise, building in them the skills through practice to enhance their confidence or self-efficacy, or addressing the bigger picture of implementation and how do we tap into those factors such as social support and the norms around them, the access they have, or the influence of important others that might, outside of the individual, really impact their ability to sustain exercise behavior change. Within social cognitive theories, there's really been strongly identified some prerequisites of people moving to action. So oftentimes, we clearly know exercise may be good for us and that we should, and I would put that should in quotation marks, be doing exercise. However, oftentimes that doesn't translate into action. And so really there's a number of prerequisites. And one is having initially that intention, like, okay, it's good for me, I'm supported to do this, I intend to exercise. Intentions alone, however, will not necessarily result in actual engagement in behavior. To do so, we need to then also build in individuals the necessary skills, so behavior change skills as well as learning about exercise, because as much as we may know it's good for us, many individuals, especially in the management of a chronic disease, may not know what is safe and what skills they have and what counts as movement or exercise. And so building in them that educational knowledge as well as the practical skills to do things can be absolutely essential. And then even when we have intentions and we can build the skills individual, we need an environment around them that supports them to be physically active. And I would argue across much of chronic disease management, this hasn't been directly embedded into clinical care settings, right? And so automatically they have environmental constraints often in clinical care settings where exercise is not the norm, where exercise is not supported, and in some cases may be actually diminished. So they may have faced more barriers because of that chronic disease management, because of the clinical care system and the lack of focus on exercise as part of an essential wellness journey or a wellness tool to help to manage their chronic disease. And so we really need to move beyond the individual and address factors around them that can be supportive of exercise behavior change. And then finally, a really big one and probably our central element within the individual to foster that adoption of exercise and move towards maintenance is this idea of self-efficacy. And self-efficacy is someone's confidence in their ability to engage, in this case, in exercise. So it's situation-specific confidence. You'll see different terms used depending on the framework, depending on the setting, but self-efficacy, sense of confidence. Oftentimes this idea of control or competencies can also mean this idea of self-efficacy. So lots of common terms, but really critical. And I like to think about this was when we build the confidence in an individual, the self-efficacy, it's really about them shifting from not seeing themselves as someone who can move more, who can be an exerciser, to being someone who sees themselves as an exerciser. And when we think about chronic disease management, I think the vast majority of individuals do not see themselves initially or as they start to deal with their disease or have dealt with it for years as someone who can live well, as someone who can exercise. And so the centrality of and the importance of self-efficacy to foster effective behavior change cannot be understated. We know from the literature and from the theory from Bandura of self-efficacy that there are really 4 primary predictors here, and these are listed in order of importance of the potential impact. And that's not to say that something at the bottom can't be more important for some individuals versus others, but in general, we know that we can build self-efficacy through past performance accomplishments. So when someone does something and they feel success at that, they're more likely to gain confidence around that task and then want to engage in that task again. You know, most of us are not gluttons for punishment. We don't want to continue to do something that we can't do or that doesn't feel good, right? So having that success is absolutely essential to building self-efficacy. And within the exercise behavior change domain, the beauty of exercise is we can tailor it to meet anybody where they're at. so that we can foster success within their initial performances by breaking exercise or movement down and working in small steps to actually move them forward. The second source of self-efficacy are vicarious experiences. So how can they really see similar others and feel that success from others and use that to impact themselves? And so really for us within exercise behavior change settings, this often can come from, first and foremost, maybe even just educational materials where they see similar others, or they read stories, or they understand that this has been done with this population and people can do this, but then it's seeing others. And so we often use group-based environments or individuals just gathering at the same time and doing their own exercise or movement, but seeing similar others doing the actual exercise or doing it with them can be a very positive source of support and building of self-efficacy. The third one is verbal persuasion, and in the exercise behavior change, that can come primarily from the qualified exercise professional, the kinesiologist, the healthcare providers can be a hugely important source of verbal persuasion to impact confidence in individuals, especially when we consider chronic disease management. And then it can be important others that provide that persuasion, or even their own self, so that positive self-talk. All of these can be really critical to building self-efficacy in individuals. And finally, the last source of self-efficacy is the interpretation really of physiological and affective states. And this is a critical one when we think about chronic disease management and for individuals with kidney disease who may not feel well, right? They may be experiencing changes, and the idea of exercise and some of the changes that come with exercise, increased heart rate, breathing harder, sweating, these can be interpreted very negatively when that's been associated with complications or issues medically in the past. And so understanding what movement can feel like, and really always targeting this notion of movement or exercise should feel good while you're doing it, and you should feel better after, right? So interpretation of those physiological states and recognition of the mental and well-being, affective or mood states from exercise can be a critical learning piece as individuals embark on this exercise behavior change journey. One of the social cognitive theories that we've used a lot in our research, and you'll see this across different exercise studies, is the theory of planned behavior. And this is just one of many. There's a number of different theories that we could put up as examples here. But the theory of planned behavior is really a fairly simple theory that can be quite effective. And any theory, whether it's the theory of planned behavior or another one, it really gives you a framework for within an exercise intervention on what you can target to impact change ultimately. And so in the theory of planned behavior, the direct predictors are someone's attitudes, subjective norm, that's really what important others to them think about exercise. So you can think of this in the context of kidney disease management as their healthcare providers, others that are important to them, family members, and the role of the kinesiologist, the qualified exercise professional. And then the last one in this is perceived behavioral control, which is very similar to self-efficacy. So this idea of I'm in control of this, I can make these choices to engage in exercise to help feel better as I manage my chronic kidney disease. So these three are direct predictors to intention, and then intention predicts behavior, as well as that perceived behavioral control, the actual behavioral control that they have over engaging in the behavior. So that's the simple direct model. And then in the picture here, you can see that behind each of those predictors of attitude, subjective norm, and perceived behavioral control are these different beliefs. And that's where really through experience, through education, and using a really exercise and educate framework, that we can help individuals become more aware of their beliefs or build beliefs that are going to foster positivity towards intending and actually engaging in exercise. So again, this is just one example. There are other social cognitive theories that are used across the research. But again, the utility or usefulness of theories is really to help us target what we would be trying to do within an intervention. What are the key variables to target to support change in intentions and changing ultimately actual behavior? Another one that we have commonly seen in the exercise behavior change literature is the stages of change model, which is really part of a larger framework, a theoretical framework called the trans-theoretical model. And so within the stages of change, it's been applied very well clinically to really help to understand where somebody is in their thinking or in their action of engaging in change, and how then we can target them through varied interventions that are tailored to where they are in their stage of change. And so you can see here, if you're not familiar with the stages of change, it moves from people not even thinking about it at pre-contemplation to thinking about exercise behavior change at contemplation to moving through some action steps, preparation, action, and ultimately to maintenance. Now, these changes are not simply straightforward. That would be one of the myths really that you'll hear about later with exercise behavior change. It's not just a simple, you take the first step and then the next one and you move forward. So the stages of change, as it's evolved, is really recognize that there can be forward, sideways, and back and forth, really movement. So somebody can be preparing to exercise and taking initial steps, and then barriers come up and they move back to just thinking about it and going, yeah, that was not as easy as I thought, right? And they didn't have the right skills to move forward to action. And so it's really important to recognize that as individuals are at various stages, yes, we can tailor to address maybe specific needs at those stages. But again, it really comes back to those predictors we talked about in building in people that confidence and then their access to the resources and the support needed to help them move ultimately towards action. And as they build the skills and see themselves as an exerciser, towards that idea of exercise maintenance. Now, the final kind of specific one that we've seen in the literature, and this comes from Michie and colleagues and part of a larger framework, is this COM-B model. And it took a look across different theories and across different approaches to go, well, what if we distilled this down to 3 key factors that we know we need to target to really implement behavior. So the COM-B stands for capability, opportunity, and motivation, and the impact of those on the actual target behavior. So in this case, exercise adherence and ultimately exercise maintenance. And so capability is really, targeting at the front end in the individual. Do they have the resources? Do they have the skills and the support? And have we built in them, that positive attitude, the sense of confidence, sense of control that they can do this? Right? The motivation is really about building within individuals and providing the resources so that they can become intrinsically motivated to engage in exercise. And so you should see right here, there's going to be links between capability and opportunities and motivation to ultimately impact behavior. Opportunity starts to move not just within the individual and their skills, but beyond that to that larger environment around them. And really critical that we're addressing within all of these, really, the barriers and facilitators that can support individuals to develop the capabilities, the motivation, and the opportunity that will foster that behavior change. So there's a lot more that goes around this COM-B. There's a behavior change wheel that really nicely targets so many of the theoretical elements we've seen targeted across different exercise interventions and really breaks it down as to what you can target. And then it's really up to the implementation team, the research team to decide, okay, within your program, here's the key elements to target. Within this patient population at this stage of their disease, here's what's relevant and what we need to do across potentially this COM-B model in particular. Now, when we think about opportunity, it's also important, again, not to just focus on the individual. And so before we get into the actual behavior change skills and I hand it over to Courtney, I want to introduce this idea of the bigger picture. So a social ecological model framework, which has been presented widely across physical activity behavior change, is really about us recognizing that behavior change cannot be simply targeted to the individual, which in exercise has been typically what we do, right? We look at the individual and we say, okay, it's up to you. This is all up to you. We're going to build the skills in you. We're going to give you the program and you just go off and do this. We know dropout happens and we're not sustaining behavior change. And so we have to move beyond the individual to consider interpersonal factors, social norms, cultural norms, the influence of healthcare providers in these clinical settings, who they have to be active with, what support they have. lots of research showing people that have pets, dogs, are more likely to build in that physical activity. And then beyond that, at the organizational level, okay, what access to facilities do they have? What education can they receive? What are the costs and fees to accessing things in their community? Bigger than that is then the built environment around them. How does that act as a barrier or a facilitator to being physically active? So everything from their neighborhood to safety in their neighborhood to seasonal variation of when they can be active in their community. And then finally, the big picture, right? The physical activity policies and health policies that maybe support integration of exercise into clinical care, into chronic disease management, into chronic kidney disease management. If every clinical setting for kidney disease had a kinesiologist, had a qualified exercise professional embedded into the system, automatically we're showing value to exercise, we're supporting it and providing access, removing barriers right away, whether that's simply educational resources or whether it's programming and exercise prescription. But really it's about moving beyond the individual to support change, considering factors around them that we can ultimately build an environment that values, supports, and encourages an active lifestyle, physical activity.
So you've just learnt about the different theories that can be used to predict behaviour change, and Nicole's just talked about what we're targeting within those theories when we move to practice, and how it all fits together in the bigger picture. Now we're going to move from evidence to practice, and drill down a bit more and look at the behaviour change skills. So what are behaviour change skills? Well, they're strategies that elicit behaviour change and can help us guide an individual through the stages of change and strengthen their motivation and self-efficacy to make the change. There's lots of different strategies that we can use, and we've put them into 4 overarching themes or categories that we can target to help move from just thinking about it to actually doing it. The first one we're going to talk about is education. Now, knowledge is key to understanding how we can support behaviour change and achieve the desired behaviour. However, not all education supports behaviour change. Whilst it's critical to explain why behaviour change needs to be made, knowledge alone is not enough to change behaviour. Increasing someone's understanding why physical activity is important, it needs to go beyond this. It needs to incorporate why and how the change can be made and aid personal awareness and skill development to produce the desired behaviour change. Education is typically one-way communication, but in order to get a lasting change in behaviour, the patient needs to be involved in the process, and it needs to be a two-way interaction. Education can be used to increase the awareness and provide a better understanding of the personal relevance of the information. Tailoring the education can increase awareness and ensure that the information is relevant to the individual. It's also more likely to include an explanation on why the information is pertinent specifically to the individual. Educational topics and themes should focus on long-term adherence and effectiveness, particularly in terms of the benefits of regular exercise and physical activity. Instructors will need lots of training and practice to understand the principles and practice of exercise and the application process, so how to apply them in appointments with your patients. These will be covered in previous modules and potentially future modules, particularly in terms of implementation. So it's important to understand what your patients will go through or may go through, and the key topics we'll cover over the next slide should be discussed and supported in class. Using patient webinars to educate, with a focus on breakout rooms, will enable discussions amongst participants about their understanding and their experiences. It's a great way to engage individuals and foster a community and build social support, which we'll discuss a bit more later on. Fostering a community is important for effective and sustainable behaviour change. The sense of community and feeling of belonging can bring people together for shared experiences and can inspire and encourage each other to promote positive outcomes and also aid celebration of accomplishments. We're going to talk a little bit about some of the educational topics that are important for facilitating behaviour change and promoting healthy behaviours. So now we're going to talk a little bit about the educational topics that should be discussed and supported to raise awareness, understanding and skill development. The first topic is the principles of exercise. So you'll have covered this in a previous module, but it's important to educate individuals about the principles of exercise and to provide participants with information on the physical and psychological benefits of physical activity, as well as information about general exercise principles. The second is goal setting. So this should include the discussion of SMART goals and also the difference between process goals and outcome goals. It should also discuss different strategies for attaining goals, and participants should be given the opportunity to set their own SMART goals. The third is behaviour change, relapse prevention and motivation. So this should discuss the steps towards positive change and the laws of behaviour change. It should also discuss relapse prevention, planning ahead and ways to maintain motivation. The fourth is stress management. So this topic should discuss the basic concepts of stress and the role of exercise in stress reduction and fatigue, which are particularly pertinent to individuals with kidney disease. It also should provide the information on the importance of sleep and the mind-body connection. And the fifth one should be social support and long-term maintenance. So this should discuss social support and different sources of social support, which we'll discuss a bit more later on. It should help participants identify different sources of support from their own life, and also provide tips on maintaining long-term physical activity beyond this programme. Alongside providing education to increase understanding and awareness, it's also important to foster behaviour change strategies, which can include setting and reviewing goals, self-monitoring, so tracking physical activity and also feedback, action planning, so having prompts or setting reminders, social support, so how to get family and friends involved to assist with the behaviour change, and also barrier management, so what to do when things don't go according to plan, or when things get in the way, or when you have a relapse. And also how to deal with these situations so that behaviour doesn't relapse. So think back to the stage of change diagram that Nicole presented earlier. So people can easily change from taking action with physical activity and engaging in exercise behaviours to not thinking about it at all. So it's important to have a safety net to avoid a complete relapse. So educating individuals on how to set SMART goals and also provide them with an opportunity to set their own SMART goals can facilitate behaviour change. So new physical activity goals should be set regularly. Should also set short-term goals, for example setting weekly goals, and long-term goals, so monthly or yearly goals. And we use the SMART principle to do this. So the first one is specific. So what do you wish to accomplish, why, and how will you do it? The second is measurable. So how do you know when you reach your goal? How can you measure your progress? The third is attainable. So you need to choose goals that are challenging but are also within your reach. This leads us on to realistic. So as we mentioned, we need to choose goals that are doable. We need to set the bar high enough to achieve a sense of accomplishment, but not so high that they're impossible to achieve. And they also need to be relevant. So what's preferred, needed and individualised. They also need to be timely. We need to set a time frame or a deadline in which we want to achieve them. And together, this includes sources of support. So we've already discussed a little bit about social support, and we're going to cover it in more detail later on. So breaking down goals into things that you can see within a certain time frame, such as a month. A goal to get fitter is not specific enough, and you cannot measure it. So by saying that you're going to walk 20 minutes twice a week is specific and it can be measured, so you know whether it's going to be completed or not. The goals need to be something that's realistic so you can actually be achieved. We don't want to be saying that we're going to walk an hour twice a week, because that's just unrealistic and not feasible. If we do this, then you'll become unmotivated and you'll relapse from making the behaviour change. Whilst I'm sure we've all heard about how important it is to set goals, there's actually little specific goal setting research. However, better adherence has been found to be associated with feasible goals, tracking of goals, resetting of goals that have not been achieved, and also setting small incremental goals. So if we look at the literature of goal setting with kidney disease, there are some studies. One is looking at setting specific exercise goals, and individuals who've reported setting specific exercise goals and achieving these have increased their self-efficacy and sustained their motivation for exercise. And whilst autonomy is considered an important factor in goal setting, most patients want their goals to be reviewed by healthcare professionals. Another study looked at step goals. So having a step goal such as 10,000 steps per day has been shown to be an important predictor of increased physical activity, decreased body mass and decreased blood pressure, which are important clinical factors for individuals with kidney disease. And also the use of patient-centred SMART goal setting, particularly focusing on diet, so fruit and veg intake, has been found to significantly improve diet quality, including fruit and veg intake and fibre intake, in individuals with stage 3 and 4 kidney disease. So now we're going to talk about action plans. This is about moving the behaviour forward. So if you write goals down, then you're much more likely to achieve them. And research has shown that if you commit to a goal by writing it down, then you're much more likely to follow through with the behaviour change. It's a very simple thing to be done, and can be done the old-fashioned way by writing it down on a piece of paper, or it can be stored on a smartphone, or it can be done using a different type of app. There's lots of methods in which to do this. And if you write in specifics such as what you're going to do and how you're going to do it, you're also much more likely to achieve it. So you need to focus first on the problem. So what is the problem? Then on the goal. So what's the goal? What do you want to achieve? And then you need to write your action plan. So the first one is the steps. So the actions that you're going to do to take to achieve your goal. To think about the people who are in charge. So who's going to help you do this? What staff members might be there to help you handle each step? Also, you need to set a timeline, so a deadline in which you want to complete each step. And also you need to think about the resources, so the assets that you need to allocate for each step. The potential barriers, so what factors can potentially hinder the completion of each step, and how you might overcome these. And also the outcome, so what's the desired result for each step. And then also you need to decide how you're going to measure your success, so what's the evidence of success, how are you going to know whether you've achieved your goal or not. And you also need to track the tracking and evaluation process, so how are you going to monitor your progress, how are you going to track what you've done, and how are you going to evaluate whether you've been successful or not. So you can use the SMART principle or the following questions that we've wrote down to help you build your action plan. So what you're going to do, how you're going to do it, what activity you're going to do, where you're going to do it, when are you going to do it, how long are you going to do it for, and when are you going to start. I've already briefly touched on social support and its importance in facilitating behaviour change. Now we're going to talk about it in a little bit more detail. So there's 4 types of social support. The first is emotional, so this helps a person cope with their emotions and experiences, and often involves showing someone that they're not alone. The second is instrumental support, so this involves providing tangible aid and service, and usually involves helping someone with their personal or medical care. Informational support, this will include offering advice, suggestions and information. And it can include knowledge or facts or advice or feedback on actions, and providing this type of advice can help people feel less anxious and stressed out about the problems that they're trying to solve. Particularly important in terms of behaviour change and any barriers that they may facilitate. And the fourth is appraisal. So this refers to the provision of feedback during performance. So it's particularly useful in terms of self-evaluation, such as congratulating someone on doing well, for accomplishing what they set out to achieve. And individuals need to perceive that there is support available, and they also need to receive support. And this is particularly important that there's both of them during times of need. So receive support is the quantity of supportive behaviours that are received by an individual. And perceived support is both the satisfaction with the support and the availability of it. Social support can come from a variety of sources, including but not limited to friends, family, spouses, partners, pets, community ties and co-workers, also peer group, and also healthcare professionals. And a wealth of research has demonstrated that different sources of social support have different influences. Social support can provide a community of change. It can support and facilitate an individual's self-regulation by enabling their adaptive capabilities to face challenges and overcome adversity. It can provide them with opportunities to engage in vicarious experiences. It can provide verbal reassurance, reduction in negative effect, and also can help reduce stress-related arousal. Self-efficacy can maintain and cultivate social support. And perceived social support has been shown to be an important predictor of health-related behaviours and can be enhanced through its effects on self-efficacy. Those who have high levels of support have higher self-efficacy, which can in turn predict better outcomes or better health-related behaviours. Providing lifestyle and exercise behaviour change support is often seen as an educational activity rather than a behaviour change activity. And studies have shown that professionals may need further support and training to successfully provide behaviour change counselling and motivational interviewing. This is what we're going to cover over the next few slides. We're going to talk about the 2 main forms of communication that are motivational counselling and health coaching. First off, we're going to talk about motivational counselling and how to build a positive motivational climate. So what is motivational counselling? It's a client-centred directive method for enhancing intrinsic motivation to change by exploring and resolving ambivalence. It's a communication style to engage and partner with a client, whether this be a fitness participant, group class member, or a patient. It's a counselling technique that provides people with an opportunity to talk about and resolve their feelings so that they can move forward with change. The aim of motivational counselling is to facilitate patient-driven decisions to change behaviour. The goal is to have the patient argue for making change, not to be told what they should do, for example, becoming more active. Counsellors can help strengthen clients' intrinsic motivation for change, and change must emanate from within the individual rather than be cast upon them by a healthcare expert. Remember, the individual is the expert in their own life. 98% of care is in the hands of the patient. There is a spirit to motivational counselling, and this includes having a partnership or collaboration. So motivational counselling is done for and with a client, not to or upon them. It takes a team approach. It's also evocative, to connect change with their own concerns and values. It can evoke patient motivation and change talk. So it's our job to call forth what's in the person that supports change. The implicit message is, you have what you need, let's find it together. And autonomy. Accept people can and do make choices. This needs to be respected, to honour patient autonomy and the right to make choices. So behaviour change techniques are best done when they're doable, measurable, efficacious and implemented with self-ownership, which can be achieved with motivational counselling. However, it often involves a shift in approach. So can you communicate and connect to known strategies or skills that can help an individual to engage in exercise behaviour change? For example, goal setting, self-monitoring, education. For example, you might say to a patient, I know it can be hard for you to fit in, so be proud of yourself for being here. Now think about why you're here. What is this class giving you? Where does this class fit into your movement week? There are 4 guiding principles to motivational counselling. They have the acronym RULE. First is R, that's resisting the righting reflex and express empathy. Don't be the one that's arguing for change. As we've said, no one likes to be told what to do. This needs to come from the patient themselves. U is understand your patient's knowledge, motivations and barriers, and develop discrepancy that supports behaviour change. You need to evoke the patient's own argument for change. L is listen. Listen to your patient and roll with the resistance. Understand their dilemma. To promote understanding. E is empower. So empower your patient by supporting. There are 4 core skills to motivational counselling. So you need to think about the style. So you need to practice guiding rather than directing. To ask open-ended questions. Ask the patient to consider how and why they might change. You should develop strategies to elicit the patient's own motivation to change. To inform by asking permission to provide information, and ask what the implications might be. To refine listening skills and respond by encouraging change talk from the patient. To listen to understand the patient's experience. You can provide brief summaries or reflective listening statements to help facilitate the argument for change. Strategies can include agenda setting, so discussing what needs to change. You can also discuss the pros and the cons, so the why change, so like why you might change. Can assess the importance and the confidence, so the why and the how. Can exchange information and also make decisions about change. We've just talked about how we can use motivational counselling to build a positive motivational climate. Now we're going to talk about how we can use health coaching to do this. So health coaching is a patient-centred approach wherein patients at least partially determine their goals. They use self-discovery or active learning processes together with content education to work towards their goals, and self-managed behaviours to increase accountability. This is all within the context of an interpersonal relationship with a coach. Health coaching can support patients to make behaviour changes. The focus is on the goals that the patient sets to address a particular health concern. And the focus is on the interaction on generating and trying out potential solutions rather than focusing on the problem itself. So the patient brings the coach information and recommendations from their treatment providers and works with the coach to decide which ones to enact, and most importantly how to do so in a way that can sustain given all that they know about their lives. Health coaching is not a provider-directed health education that stems from the instinct to convey, rather than discuss, and should create consensus around medical knowledge associated with a particular problem. especially when it presents itself. There are some key concepts to consider when health coaching. The first is exploring patients' experiences. So the process needs to be patient-directed with goal setting based on the patient's ideas, experiences and choices. Coaches should ask participants what their goals are. They should use open-ended questions such as, what do you want your plan to be for the next couple of weeks? It needs to be non-judgmental and refrain from evaluating the patient's choices, whether or not he or she has met the goals that are set. You also need to think about reframing, so different interpretation, often to broaden participants' perspectives, to help them find a positive spin or to overcome a barrier or ambivalence. Provide tentative suggestions or advice. Suggestions should either preface by a request for permission to offer them, such as, can I give you a suggestion there? Or pose as a question such as, do you want to set that as one of your goals too? Sometimes a suggestion should be directive, yet still phrased in the form of a question or very tentative. For example, have you considered a trainer? What about another time of day for your workout? Maybe you could add strength training to your workout. You should offer information or rationale for approach, particularly in terms of a goal or a barrier to a goal. You can offer other resources and refer to information offered in the group sessions or information offered from other resources. You should promote the participants to explore or remind them of the information or a motivating rationale the participant already has. The health coaches can ask questions such as, how does that help? What do you know about that? And what else could you do? To help participants strengthen the rationale for investigating other alternatives, health coaches can refer an experience that the participant has already reported. And the final one is guiding to specifics, to guide the participant to specific goals. During sessions, participants should be introduced to the skill of setting SMART goals, which we've already covered a bit earlier on. The health coaching process involves linking goals to values and sense of purpose. So what's the participant's motivation and what's their purpose for the change? There should be a reliance on self-discovery. So it's an active learning process that can nurture their sense of autonomy, resilience, positivity and support. We also need to meet patients where they need to take time to understand where they come from and what might be influencing them, and also incorporate mechanisms for developing accountability in their behaviour. And for health coaching process to be successful, it needs time, commitment and motivation from both parties, so both from the health coach and the patient themselves. There are a number of essential components for health coaching that take time to develop. The first is building trust. So trust needs to be built with the individual coach and the patient. And if there's group coaching, this needs to include all the group members. Need to experience support. So clients need to experience support from the coach and the group if relevant. This is one of the key generative aspects of the change process. Need to acquire knowledge. So clients or patients need to acquire knowledge of their health risks to be able to set realistic goals. To be able to create a vision. So to be able to create a vision of what they'd like their health to be, and to gain clarity on their personal values, reflect on the meaning of their life or their purpose, and connect specific desired health behaviours to the sense of meaning. It's to learn the use of the coaching process to create SMART goals and develop small, durable action steps. Participants need to experience success in forming new habits which can, in turn, create changes in motivation and physiology. And participants need to maintain new health behaviours and receive support for this. So as I'm sure it comes to you as no surprise, you need to ask lots of open-ended questions. For example, asking, why are you here? What do you want to get out of class today? Or what do you want to get from this programme? What changes are you looking for? And what will be your markers for seeing change? And to provide motivational options. And to exchange information. So we need to elicit, ask what the patient knows or what they'd like to know, or if it's okay for you to offer information. For example, what do you know about exercise behaviours, or what do you know about exercise principles? Can I share some information with you? You need to provide information in a neutral, non-judgmental fashion, so avoid using I and you, and use other things such as research suggests, or studies have shown, or others have benefited from. And you need to elicit the patient's interpretation. So what does this mean for you? How can I help? And where does it leave you? You need to make decisions about change to prompt action and include goal setting and action planning. So we've just covered behaviour change strategies and communication. Now Nicole's going to take over and talk about behaviour change pathway and the complex process, and also discuss some myths and facts with you.
So you've now have heard from Dr. Lightfoot around the behavior change skills and communication approaches, and really how can we take some of the evidence and move it into practice. It's really important to recognize at the end of the day, the behavior change pathway and the exercise behavior change pathway can be very complicated, and it's not simply what is often presented out there in the media in talks about exercise, that if we build all this, it's easy, it's going to happen, just boom, 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 and all these steps, and that it's one size fits all and up to the individual. You heard me speak earlier about taking that bigger picture approach, the social ecological model, and the need to really tailor depending on where an individual is. So yes, ultimately we are tailoring our interventions to support the behavior change, build those skills that you heard from Dr. Lightfoot about, and really build that environment through a positive motivational approach, ensuring communication is strong and that exercise is valued. All of those pieces will build that stronger environment. But ultimately, we need to take exercise prescription and absolutely tailor it to meet the individual where they are, right? Wherever they are in their chronic kidney disease management is where we absolutely need to meet them. And we need to start low and progress slow. So as we embark on building exercise adherence, we really need to consider the individual and where they're at, what they're comfortable with, and start with little steps. Start with this idea of movement and physical activity before we build up to an exercise prescription. Ultimately, to go back to this idea of self-efficacy, is we need to build in individuals the tools within them that will enhance their competence, their sense of self as an exerciser. And we know that individuals' willingness to try new activities, to build the habit of exercise, is strongly tied to their perceptions of their ability or their competence, right? So within whatever you are delivering, a study, an intervention, an implementation program, and you'll hear more about implementation in Module 8, critical that we provide sufficient practice time. We teach from the positive, so this positive motivational climate through all of our communication and approach is absolutely essential. We want to emphasize what the individual can do and their personal improvement versus any of that shoulding on them, right? What they should be doing. What can they do? Give them positive feedback, help them progress, and emphasize where they were and where they are and where they could be going to. Ultimately, when we provide a positive motivational climate, we're able to encourage and motivate individuals to support their exercise behavior change. So as you think about everything that you've gone through over the series of slides in this module, here's an opportunity to really put that into practice. So I encourage you to take a look at this case study that we've called the non-committal exerciser. And as a trained fitness professional with a positive motivational approach and using that health coaching idea and motivational counseling, think about how you would approach a tailored program for this individual that can address the motivation as well as the logistical needs, right? So as an exercise professional, still using your skills and your knowledge of exercise, but what do you need to consider for this case to move her to start moving more, to start exercising, considering all of the other logistical, practical, and affective components to the case that she presents. So take some time for yourself to jot down your ideas of how would you truly support this individual to start to build the habit of exercise adherence, and maybe then considering at what key points would the progressions happen or other information come in to move them forward to exercise maintenance. Across the slides, you've seen a number of references or theories that we've brought up. So here's a resource list. I encourage you, if you're interested in understanding more the theoretical determinants of behavior change, to take a look at some of these examples.
take a moment to evaluate your knowledge with the following self-assessment questions. Feel free to pause the video at each question to identify the correct answer. The correct answers can be found on the GREX website.